series. We are honored to have Dr. Amisha Parekh Campos as our esteemed speaker tonight. Dr. Parekh Campos's talk title is Barriers and Facilitators to End-of-Life Care for Black Urban Populations. A warm welcome. My name is Shiva, and I serve as the chair of the CPA Social Justice Committee. Joining me today are our passionate social justice members, Beth, Kyler, Sydney, and Andrew. Also, I want to say thank you to all sponsors. As you know, the Social Justice Speaker Series serve as a catalyst for our common goals to empower ourselves, our clients, and the community we serve. To sustain this critical work for you, we rely on fundraising and the generosity of those who believe in the power of education, and awareness of our biases is critical. We sincerely appreciate all donations moving forward and are truly grateful to our sponsors. Your support is the foundation that keeps this vital work alive and thriving. I'm going to share with you the donation slides. As you see here, we have comprehensive neuropsychological services who donated us for the 5th consecutive year, for which we are so grateful. Also, the CPA Educational Foundation have donated us for the 3rd consecutive year. You also see the name of our supporter. So we're really grateful for this support, and I'm going to turn it over to Andrew to share with you additional information.
Hello, everyone. On behalf of the Planning Committee, we are thrilled that you could join us for this evening, and we sincerely hope that you will continue to attend our future speaker series sessions. We are enthusiastic about Dr. Parekh Campos' presentation this evening. And as a brief reminder, the CPA Social Justice Speaker Series offers free monthly meetings to CPA members and the wider Connecticut community, as well as our nationwide supporters. I welcome you to our speaker series this evening. I'll now hand it over to Beth to present the biography of our speaker.
Thank you, Andrew. Amisha Parekh Campos, PhD, MPH, RN, CHPN, is the Assistant Clinical Professor at the University of Connecticut School of Nursing and Quality and Education Coordinator for Middlesex Health Hospice Program. She holds a PhD in nursing from UConn, an MPH in global health, and a BS from George Washington University, along with a BSN from University of St. Joseph. With over a decade in hospice home care leadership, Amisha manages research, quality, and education for a program serving 150,000 people in Connecticut. Her research focuses on end-of-life care communication, particularly addressing disparities among Black communities. She is a Robert Wood Johnson Future of Nursing Scholar, Jonas Scholar, and recipient of the 2021 Certified Hospice and Palliative Nurse of the Year, and Young Investigator Award from the Connecticut Coalition to Improve End-of-Life Care. It is now my distinct honor to invite Dr. Parekh Campos to lead us through what promises to be an insightful and inspiring presentation. Okay, the platform is yours.
Great, thank you so much, and thank you for inviting me to this speaker series. I'm very honored, and I'm glad I'm able to share this latest research that I've done, which I think it'll be, it was eye-opening for me, I have to say. So I hope it's the same for you. So I'm going to share my screen, and I'll give you a little bit of background about the project. Just as Beth had mentioned, I am an assistant clinical professor at the University of Connecticut School of Nursing, but I'm also part of the hospice program at Middlesex Health. And I have the fortunate position of being a joint appointment where I do get to still do clinical work while doing academic work at the same time. So it's a good bridge between the two different sites. So what I did is really look at barriers and facilitators to end-of-life care among Blacks in an urban setting. And this urban setting is in Connecticut. It is in Middlesex County. And I'll go into those details a little bit further. But I just wanted to give you a little bit of background of why I chose this topic in particular. When I started in hospice, which was about 15 years ago, I hadn't really suffered much loss at the end of life. And I have had a few family members who have died, but didn't really understand what went on because I was very young. And then as time goes on, we all age, and I became older too, and I've had recently a lot of losses and a lot of people that are very close in my life. And I've seen a little bit of the disparity that exists. As someone who is also a minority, who has a different cultural background, I'm Hindu, and I had family members who went through end-of-life experiences. Aside from the barriers of just, going through the process, there was a lack of cultural understanding. So I really wanted to explore this a little bit further. And then being a part of the hospice program for as many years as I have, I noticed a very homogeneous patient population that we serve. And it was a little bit disturbing to me that, when I really looked into the research, we only serve about, I would say, 5% of our population total within a 5-year period, which I'll again go into a little bit further, is people of color. So that's what kind of prompted me to get into this type of research. So I just wanted to acknowledge the University of Connecticut for helping fund this project. If it wasn't for the Office of Vice President of Program Research, I wouldn't be able to do this. And then Middlesex Health Hospice was an essential part of this because, one, they collaborated really well with what I wanted to do. They supported the vision of this project and allowed the time for me to complete it. So just as an introduction, health disparities among vulnerable populations are a big problem in the US. There are many factors that impact this, and we have heard of, the numerous reasons why the access to care isn't there for a lot of populations. Social determinants of health guide one of those factors, spiritual values. Aside from provider level barriers, there's also cultural barriers. As Americans in a society, we don't really accept end of life as a topic as much as other countries in general that talk about death and death practices a little bit more openly. We have other barriers too, as far as education and people understanding what end of life is and what the process is and what resources are available. And in this country, many of the programs are set up the same way. So structurally, they're designed for a certain person that doesn't necessarily include differences in culture or religions or ethnicities or values. So there's many studies out there that have revealed that there are a lot of racial and ethnic disparities, and people of color in general are more likely to die in the hospital compared to those at home, although about 80% of those who express their wishes want to die at home, yet there's only about 20% of those that actually are able to die at home. A lot of them do end up dying in the hospital. And those that are of color also are less likely to engage in end-of-life planning. And one of the things that I've seen in the research and the literature is that many cultural groups are framed as not being open to services. For example, there was a study I was recently reading that stated that the reason African Americans don't receive the same type of end-of-life care is because their spiritual values are different, and that's a barrier to gain access. Others that I've read too, and there's a researcher who does a lot of work with the Hindu population as well, is that because we are more family centered and listen to family members more, that's one of the barriers why advanced directives aren't completed. So the way the research is posed and is presented to us is almost blaming cultures for not having the access to services instead of really exploring why there is a lack of access to it. So one of the things I wanted to look at is about this access. What is this access barrier? It's not necessarily that cultures don't have the ability to get services related to end of life or palliative care. It's more about them not having the opportunity for even having that access or the education for seeking out access. So it's a little bit bigger than just, X, Y, and Z are the barriers for why something might not be happening. So to look at this further, I did look at Middletown, which is an urban area of Middlesex County, and our hospice program and our health system serves Middlesex County. We're a community hospital. So this is kind of where my interest stemmed as far as looking at this population. The participants, and when all is said and done, don't necessarily go to Middlesex Health for their healthcare, but I had the opportunity to be a part of this community, which was within reach. So that's why through Middlesex Health and the community programs that we have, I was able to access this population. So looking at Middletown, Connecticut, Middletown is the focus of this particular project. It's considered an urban periphery, so an urban area, and out of all of the counties or out of the towns in the county, Middletown has the most diverse demographic population. And every 3 years, the health system does a community needs assessment to determine the makeup of the community, essentially. So looking at the 2019 community needs assessment, I was able to gather some of the demographic data of the city. There was another community needs assessment that was done 3 years later. However, that information was really limited because of COVID. It happened to be, right after that time, and to gather the data wasn't as specific. So looking at some of the rough demographic data that's come out with a more recent survey, some of the numbers are essentially around the same. So I still am using the 2019 data. But overall, Middletown's total poverty rate is 11.3%, which exceeds Connecticut's overall poverty rate, which is 10.1%. It's pronounced significantly more among Blacks when compared to the white population. And the community needs assessment goes into further detail and breaks down different social determinants of health to really look at the population. Other information that I gathered from it was data on life expectancy, premature mortality, and years of potential lost life. And again, there were many disparities among the Black population when compared to the white population or even the Hispanic population in the city. And life expectancy was less, premature mortality was greater among the Black population, and years of potential lost life was also greater. So having this information and also the anecdotal information just from being a part of this program for the past 15 years or so, and not seeing many people of color on service with us when it comes to hospice or even our palliative care services with consults, I wanted to dig into this a little bit further. So in over a 5-year period, and this project has been over the past 2 years. So this information comes with a 2-year lag with it. But looking at 5 years of data from EPIC, from our EMR, and looking at all of the palliative care and all of the hospice services that we provide, which we have a palliative medicine line, and then we have our hospice home care program. And with that, as far as looking through the demographics, and it's all self-reported, so that's why I say it's rough data. Only 4% of all of the patients we had within that 5-year span identified as Black or African American that were from Middletown. So there's definitely a big discrepancy when it comes to that. The total population of Middletown, the percentage of those that identify as Black or African American is almost 20%. So there's definitely a discrepancy occurring here. So I wanted to see why there was such a small percentage of patients with palliative care or hospice services that identified as Black or African American. So the approach I used for this, and I might say that use myself in the first person with this presentation, but it was a whole team of us that really worked on this project. We use CBPR, which is community-based participatory research, which is a collaborative research approach that involves community members in the project planning, the project development, recruitment, all steps of the project plan. And the reason I wanted to do this was because I didn't want to be a member of, someone in society coming into a community and saying, hey, why is this happening? I really want to see, what's going on, without really gaining perspective from those that are in the community before, delving into this topic. I'm an outsider and I really didn't want to intrude because I can't imagine if the same happened to me in my community. So if someone had entered, wanting to know about Hindus' perspectives on end-of-life care and without any background, without me really knowing them, without them having any credibility, I'm not sure I'd be too open to that. So that's why I wanted to work with this particular approach. And I also have a mentor at the University of Alabama, Birmingham, Ronit Elk, who has done a lot of PhD student training and also a lot of her own work on CBPR training with palliative care, specifically among African-American patients as well, and determining what the barriers are. And she's developed a whole research base on this type of approach. CBPR is not used in nursing very often. I think it's used in more frequently in other fields. I believe in psychology and public health. But in nursing, we haven't utilized it as much as we could. So an overview of the project, kind of going step by step, is that I received funding from the University of Connecticut. And then I developed this community advisory board. And I'm going to go into who is part of this community advisory board. I had their permission to disclose their names and what they're affiliated with, just because I really want to show the significance of this partnership. They were essential with this whole project. So I really do want to highlight and spotlight them as much as I can. It did take 1 year approximately to develop these relationships. They had to learn to trust me. I had to, figure out what their availability was, if they were interested in a project like this, if they were a good fit. We both were kind of feeling each other out to see if this was something that we would both be able to do well together. And so having meetings, one-on-one talks, a lot of these community advisory board members have been through loss, and a lot of people in general have been through loss. So they could relate to some of the information that I was talking about, some of the questions I had about, what the barriers might be, what some things that are helpful to them might be. So we really did take some time to get to know each other, develop that rapport. And then as a group together, we also had to make sure that everyone meshed together. So once we all were on board with the project and in sync, we designed it. So that included creating the whole plan for the project, for figuring out recruitment strategies, figuring out what the best approach was for the population, and also designing the questions for the interview process. So the outline, the methodology of this study was basically developing that community advisory board and then recruiting individuals for qualitative interviews. So we would interview them for 1 hour, talk about the barriers and facilitators of end-of-life care. And even then we backed up a little bit because end of life was a word that wouldn't be very acceptable with the participants. So we changed that a little bit. So the criteria for recruitment was anyone who was diagnosed with a serious illness or had taken care of someone with a serious illness that lived in Middletown and that was willing to be interviewed for 1 hour and recorded. So we talked about that. Even the flyers, I had kind of come up with rough drafts of everything, and they came in and kind of, said, all right, this isn't going to work. We're going to do this instead. They thought the flyer was really drab. They wanted more color. They wanted a picture of me on it. They wanted, all these things that they knew would be more engaging for those in their community. which was great because I kind of drafted something that was preliminary, and they were the ones who refined it and were able to give valuable input into it. So after we were able to go through all of those steps, the participants that were interviewed, there were 11 of them total, and I'm going to go into the more information about them and then the findings. But once the 11 participants were interviewed, then I went back to the community advisory board to talk to them about what the findings were and seeing if it was similar to, you know, what their thoughts were about some of these questions. And then after that, another faculty member from the University of Connecticut, who's a qualitative expert, helped with coding and creating themes for the qualitative interviews. And then I went back to the community advisory board to again talk about these themes. Do they make sense from, you know, some of the quotes that we gathered and from the interviews? Is this relatable? Is this something that you also see within this group? So throughout this whole process, it really was a back and forth with the advisory board to make sure they were involved and make sure that their input was heard, and also that they were able to make changes to this as we went along, just so that it made sense for their own community. So this is the community advisory board. There are 5 people. 2 of them are reverends. Reverend Robin Anderson is at Cross Street AME Zion Church, and all of these locations are in Middletown. Reverend Deborah Hopkins is part of Shiloh Christian Church. Ms. Carrie Kinsey is one of the directors at the Free Center, which is a community organization. It's a building, a facility that she developed where people, and she specifically geared it towards people of color, can come and gather, and everything is donation based. She doesn't charge user fee. She really wants people to be able to gather, have a safe space to come, and even if it's programs that are you know, that meet once a month, she is, you know, willing to open up her doors for that once a week. She has men's groups there, dance classes, and all sorts of things. So it's a beautiful space. We had all of our meetings there as well, and she was able to open up her doors to me. And it's something that she's really passionate about. And there's another equivalent one in Hartford as well. Miss Anita Ford Saunders is the NAACP Middletown chapter president. And then Mr. Anthony Williams is the Beeman Middle School counselor, who was just recognized as one of the 2025 Teachers of the Year. So again, to make sure that there was equal partnership between the Community Advisory Board and our research team, we would repeatedly meet on a regular basis. If we weren't meeting, I was giving them updates through emails or almost like a newsletter form. We had a little bit of a lull when it came to participant recruitment. So in that time, I really wanted to make sure that they knew that the project was progressing and that we still were aiming to, you know, recruit a certain amount of people. And the last meeting that we had was talking about the results and talking about, okay, what are the next steps? So I went in with the purpose of not necessarily just gathering all this information and leaving this community high and dry, but actually doing something with it. So they were really bursting with ideas as far as what interventions we can do at, you know, first at a very simple, you know, level, and then ramping it up more, just to be able to give opportunity to this community to learn about palliative care and end-of-life care, about advanced care planning, about just talking about, you know, preferences and wishes and things like that. So the last meeting we had was about brainstorming, and then now we're in the phase of disseminating these findings and then going into our next steps. So far, we are collaboratively working on a manuscript to get published. I presented at the Annual Assembly of Hospice and Palliative Nursing and also the American Association of Hospice and Palliative Medicine in February about this project. And the one thing I'm excited about that's coming up is the Connecticut Hospice and Palliative Summit is taking place in May. and 3 of the community advisory board members will be there to talk about this project. And I'm going to be able to moderate a panel with the 3 of them on, but the goal is really to again, highlight them and the work that they've done to get this project moving forward. So going back to the participants and the results of this study, the criteria for those who want to participate, I mentioned before, is that they have to be individuals who identify as Black or African American, live in Middletown, be available for a 1-hour interview, and then have a serious illness or have taken care of someone with a serious illness. And once again, we made sure that this wasn't limited to those who necessarily worked or were patients or associated with Middlesex Health. This was, Middlesex Health did a lot to support this project, but they weren't necessarily involved in any way as far as needing patients from the facility or patients who would be former patients at the hospital at any point. So we define serious illness, which is one of the conceptual definitions that's out there, as a health condition that carries a high risk of mortality and either negatively impacts a person's daily function or quality of life, or excessively strains their caregivers. So for results, we had 11 participants, like I mentioned before. Ages ranged from 35 to 74, so we had kind of the whole gamut of age groups. Ethnicity, those identified as African American or Black. Other, there's multiracial. There was one multiracial participant in it, so others included as well. Most were female, but I am happy that we did have some male participants, because generally when it comes to palliative care research or when it comes to caregiver research, it's generally female dominated. So I'm happy we had, some males that participated as well. Marital status was a variety of different relationship statuses. Education and household income are listed here as well. The one thing that, I do want to point out, which may be a bias, is that for education, there are a lot of, the majority are college educated or master's levels educated participants. And so because of that, the results may have been different if we had participants that weren't necessarily as well educated, because they might know more about this topic, may know more about the medical field, may know more just about how to navigate things. But again, that's an assumption, but I think the results might have been a little bit different if that was a little bit more diverse. In addition to having the interviewed, which was a semi-structured interview, so a lot of open-ended questions, we also had additional questions for the demographic part of the survey. One was, do you have access to medical care that you need? And all participants said yes, most of the time. Do you have access to transportation to get essential goods? Most of the respondents said yes most of the time, and there was 2 that said yes some of the time. Do you live in a home that is safe and located in a safe area? All replied yes. And I have the support I need from those around me. 9 replied yes, and 2 replied somewhat. So again, looking at these questions, if we had any answers that were no, that I don't feel safe or I don't have access, the results may have been a little bit different based on these responses. So here are the findings. These are the themes that came out of the interviews, along with sub-themes with it. So the first one was about advanced care planning. And the theme there really looks at, if people are talking about it and if they're avoiding the topic. And I'm going to go into this a little bit more when we break down the themes, but it was a topic that was discussed. So there were instances of that. However, as far as the discussion and the context of the discussion, it varied from person to person. The second theme was health systems, and the sub-themes from that were participants felt betrayed by the health system. They felt like they had to advocate for themselves, and they found a difference in their care overall in the long term when they had a great clinician. So that clinician made a huge difference in their whole trajectory of care when all is said and done. As far as family as a theme, they found that they had a lot of family support, That was a big part of it. They relied on their family. The first, when we would ask, who supports you, family was always the top answer. However, a lot of them expressed toll in caregiving. So if they were caring for someone, and even those that had a serious illness, they also felt like they were caregiving to someone else. So even though the person that was interviewed had a serious illness, they were still caretakers to other people. So that became problematic for them too. So it's a layered type of situation where they want to support their families, but they're also exhausted at the same time. Lack of knowing was the fourth theme that came out. They needed to educate themselves. They weren't aware of a lot of things that were out there as far as resources and services, and there was just a lack of knowledge on a lot of programs that were out there as well. And then a lot expressed that they couldn't navigate the health system, so complex that some of the things that they didn't realize that they could have or have access to, they weren't aware about it unless someone else showed them how to do it, or they had someone in the family who had a little bit of knowledge about ways to navigate the health system, or they might have found out after the fact too. And then the last one, personal struggles. This was really among those that took care of loved ones, but it was also among those who had their own serious illness. So all of this kind of resonated for both different types of participants. How do I recover is someone, who might have been impacted with a serious illness and how they come back from that. But it's also, having this role as a caretaker for someone for such a long time and, being with them constantly. But then when they do die, it's almost having to recover from that and figure out who their identity is after that process. Another theme under that is how I've managed. So managing, again, and it kind of goes a little bit to this concept of, this point in time in their lives where they have to change roles or they have to adjust to a whole different type of life. And then letting go of former life, again, along the same type of thing, same type of theme where maybe before they were able to socialize more, but now they are a caretaker, they weren't able to do that. Maybe before they were able to do more things physically and cognitively, but now they're impacted with their serious illness, so they're not able to, and they have to figure out how to live their lives in that way. This is just a quick chart that shows of the interviews that were all done, the number of quotes that came out of it were, in the hundreds, but the ones that had the most quotes, the theme that had the most quotes was personal struggles. So that last theme that I mentioned before, that was a big part of one of the barriers to palliative care and end-of-life care was their own personal struggles with it. So there was a lot of emphasis on not being able to manage, and maybe, medically, as far as managing when it came to physical symptoms and, being able to provide that custodial care for that patient, they were able to manage that. But as far as emotionally and mentally, they struggled a lot with it, which they weren't able to really express during that time, either when they were a caregiver or when they were going through their own serious illness trajectory at that point. The other themes here, health systems, lack of knowing, and family, were also, equally, themes that came up, but not as much as personal struggles. And then advanced care planning, we'll talk about a little bit of that too. So in this next part, I do have quotes that were pulled from these interviews, and I just wanted to go into them in a little bit more in depth. So advanced care planning, and advanced care planning is a complex concept. It's one of those things where you might think about advanced care planning as, okay, planning for what might happen in the future. But there's so many parts of it that it can be really complicated. So in these two quotes that are on the screen right now, they're from the same participant. So it was one of those things that I found interesting, was that the first quote was about planning. So last year we got together with her, and this participant's referring to her mother. We got a lawyer, so we did a will, a financial affidavit or something, where we have financial control, and we did the health. Both my brother and I have decisions, and then she was saying as far, do not resuscitate. We had those discussions. So there was talk about planning for her mother and the future. However, in the second quote, she says, I know I keep asking my brother, what are we going to do? He doesn't want to talk about it. It's like, who's going to make that move? Like, who's going to move in with her? We're both like, I don't want to go back to this house, but he has his own. I have my own. My mother has the multifamily house. So within this interview, the participants said that they had, POA established as far as for medical and financial, which was great. But at the same time, she was also saying that they hadn't really figured out what to do when her mom got worse, and someone had to be with her as a primary caregiver. So a lot of the times when advanced care planning came up with these participants, a lot of them said, that they had the funeral all set. They knew where or what their loved ones wanted as far as cremation or memorial service or whatever it might be. They knew, what they were going to do with the house and things like that. And it seemed almost like advanced care planning was about after death rather than planning for what they would do before death. So a lot of the conversations about needing to hire more help, or what if someone has a decline and we need to do X, Y, and Z. Maybe we need to have mom go to a nursing home. Those conversations weren't necessarily being had. It was more about after death. And from my perspective, I can kind of see how that would be a barrier, having that conversation, because you have to acknowledge that someone is getting more and more sick to the point where they will die. It might be a little bit, I don't know about easier, but it might be more feasible to talk about after death, because it's almost that point that everyone realizes that they're going to have to figure things out. The next theme was the health system, and some of the things under that was the importance of advocacy, and then a quote on how a clinician was great, and that's what changed perceptions about healthcare also, but also about palliative care in general. And this particular quote is for one participant, of course, but this is a quote that has been repeated by many participants. So it was one of those themes that once they found someone that really understood them, that had a good rapport, that's what really created that great relationship and the great care that they believe they received. So the first one about advocacy, we shouldn't have to advocate so hard. The sad thing is, if you don't know how to advocate for yourself, you're not going to get to know you're not going to know what to do, what to say, and what that you're not receiving. And a lot of the participants had some background in, an outskirts of medical knowledge or the process of the way the health system works. So they were able to advocate for themselves because they knew that, okay, there's something here missing. So I need to speak up a little bit more. I need to be that squeaky wheel. However, a lot of people within this community don't have that background or have that person that they can rely on that will give them information about what to do next. So this became a big part of a lot of people's worries about, not being able to speak up or know what to speak up about. And then about this clinician, that was what the participant thought changed the trajectory of his care. He said, and so, I changed internal medicine to somebody who was a person of color. Okay, so, obviously you have to have some medical understanding. Then I told him what I do for a living. So this participant in particular had a little bit of a medical background. He's like, okay. And then this next response was like, so I'm not going to treat you like an idiot. I'm not going to talk to you like you're in kindergarten. And a lot of the participants did feel like they were talked down to often, just with their healthcare in general, or that clinicians were condescending to them. More with the health system theme, the reputation of the health system that came up. I'm just another patient among thousands, so don't make me feel that way. At least make me feel that I'm somebody and you're looking out for my well-being. And then the last quote talks about some frustration with the health system and feeling betrayed. This is a participant who talked about her mother who's had pain management issues for years. You're stereotyping her, and she's an elderly woman who's in pain and has a history of it because she's been going to that same doctor for years. You guys are telling her to take Tylenol. She's beyond that, and I'm tired of feeling like we're being discriminated against. All right, so there's a couple more themes. Family was the next one, where there was quotes regarding family support. So a lot of the participants felt very supported by their families. But at the same time, like I mentioned before, a lot of the participants who were caretakers felt a toll on their lives in general, and trying to balance, working, taking care of their loved one, taking care of the needs of their own family as well. It really became a lot for many of the participants. And in the second quote, but she just needs help around the clock, and I'm usually here, the one that has to help with everything, like cleaning, cooking, stuff like that. If she needed anything, I'm usually the one that has to do that. So this particular participant, mentioned how she's the primary one who takes care of her mother. Mother, really doesn't want anyone else to do it, and she will drop anything to do it. But at the same time, she's exhausted every day, and she stops in 3 times a day to see her mother. And she tries to balance that with also balancing her kids' needs and her husband's needs. So she's very happy that her mother is there, and she can, help her out, but at the same time, she's exhausted. So there is that conflict there with her. And then a lot of these participants were also the managers of their household. So as far as caretakers, they are known to be the caretaker of the whole family. So when it came to extended family, parents, they were the ones to step in. And this last quote talks about one of the participants who said that she raised her sister. So I raised my sister, I helped my brother, and I'm constantly helping my father. He's 92 years old and suffers from major depression. So that was another big theme that came out, a common pattern of how a lot of these caretakers were not necessarily just caretakers of their loved one who happen to have a serious illness, but they are caretakers of the whole family, and really the ones that people look up to manage things. Lack of knowing and lack of, not knowing that there's resources out there was the fourth theme. And then the top and the bottom quote talk about lack of. So, and it's so hard, lack of education, lack of opportunity to receive the education makes it hard. And that was the thing. It wasn't as if these participants weren't willing to learn about resources at end of life. It was never presented to them. They would never had the opportunity to even ask a question because they had no idea. I was not knowledgeable on what death really was. I thought I was going to see like an eruption or something exploding. I just have some crazy thoughts in my mind. So again, not knowing about how end of life is going to look like, not knowing about what to expect. There was never an opportunity to even get to that place because of the barriers that they had encountered before then. And then when it came to difficulty navigating, they're not giving you the resources unless you find someone, but a lot of times I have to look it up myself. So often the participants said that they felt alone, that they had to figure stuff out on their own. There wasn't any help for them to really do that. And then finally, personal struggles. These quotes talked about how a participant managed after she had a stroke herself and had some deficits from it. It took a toll on me because I do have memory loss. The good thing about the memory loss is that I don't remember negative things, hurtful things. And when the hurtful things do come back, they really do hurt. So she also referenced how her illness is not necessarily apparent. No, you can't really see a person who's struggling like she was. She had a lot of cognitive deficits from her stroke, but not necessarily any physical ones. So when she wasn't able to work the way she did before that, and people noticed it, she felt really hurt because they weren't really seeing that she was disabled, that she had a serious illness, because she had another stroke shortly after that. And she just felt that people didn't understand her perspective anymore, or where she was coming from. So that's when she had to change what her new norm is and what her capabilities were and how to move forward with that. So this is a lot of information I know I just gave to you, but when we met the last time, our community advisory board, which was the end of last year, we discussed the interventions that were possible and ways to establish trust in the community. One of the biggest themes that came up was by going to the community to have discussions like this, and not necessarily a talk on palliative care or end of life care or what that is or anything like that, but more of a conversation about preferences and wishes. And with the community advisory board, I did a game called Go Wish, where you pick 5 cards that list different priorities for you as far as what's important at the end of life. And they thought this was a great method to just start a discussion about that. Not necessarily talk about, okay, before you die, let's figure things out, but more about, okay, what's important in your life right now? And if you tell me what's important in your life right now, does anyone else know this? Does your spouse know this? Does your, parent know this? How are you going to be able to express your wishes to someone if you're holding them with you instead of telling someone else about it? So they were open to having, discussions like this integrated with existing programs that they have at the churches. There's a lot of social events that are associated with the churches. There's a whole ministerial program where a few of the churches come together in this event. And one of the things that they suggested was to have an activity where you can kind of weave this conversation in it. So it wouldn't necessarily be a workshop. Let's talk about, planning, more about like, let's do a cooking class together and then figure out a way to have this conversation in a setting that's very informal. So they had a lot of fantastic ideas. So we're continuing to work on that, coming up with the ideas. The big barrier right now, which everyone is aware of, is funding. I did have funding for the next steps of this project, but lost it with the new year that came in. So with that, definitely had my little pity party for a day, but then the community advisory board has been really supportive about moving through this and making sure that we push forward, even if with all the barriers that are there, with trying to find fundings. And everyone's been really great about exploring different opportunities and things like that. So those are the next steps, is to keep going with this and to continue this work. All right, so that's all I had. It's a very quick overview of the project, but some of the information that's come out of it. Does anyone have any
Thank you
questions?
so much. That was very informational, because this is something that we usually don't talk about it. And the way you want to approach in your next step is critical. I have one question. How did you reward end of life?
So we use serious illness instead of end of life. And then the way we defined it was, something that impacts your daily activity, something that is is functionally making you incapable of doing what you did before. So it was more of a softer definition of it rather than it being end of life, because at a certain point we weren't necessarily talking about end of life. We were talking about more about if someone got really sick, what would you do from there?
Thank you. So is there anyone who have questions about this? Probably we see some patients also with these conditions.
Yeah, I think just what comes up for me is the kind of expectation that with this population, I tend to just automatically think older individuals, much older individuals, and how much of a shift in just the conversations around this have come in the last, generation or so. And so I don't know if it's wishful thinking or hopeful or something to that effect of, as we progress as a society, to be more comfortable in having these conversations and to be more open to expressing, a need for assistance or desire for assistance, that hopefully kind of bridges the gap here a little bit. But there's a lot of when I see individuals who are particularly older, a lot of it is still, I'm the one who's supposed to take care of the family. Nobody's supposed to take care of me. I don't need anything else. And I'm just like, you can't even use your own stairs. Like, what do you mean you're supposed to care for people? So it is a little bit of a shock, but yeah, thank you for that.
Thank you.
I was wondering about the difference between, if there was a difference, and I know that you said that there was a spectrum, but if there was any difference between the patients and the caregivers.
Yeah, that's a good question. So there was a difference, just because of the different role that was taken. But I have to say that most of those that had a serious illness and identified as them having serious illness were also caregivers. So they had both perspectives, and I was able to get both of those. And some, there's one particular one, she actually developed the serious illness being a caretaker, and is now, trying to her loved one passed, and so now she's trying to, figure out what to do with herself, and again, that role change has been a big factor for her.
I noticed, Amisha, that I use the word caregiver and you use the word caretaker. Is there a right way to say that?
I don't think so. I think caretaker is what I heard a little bit more during the interviews. But that's another great point, is that the difference in the language of caregiver, caretaker. But during the interviews, I heard caretaker a little bit more.
Yes, Dr. Moore.
Yeah, I was just going to say, I think this is so fascinating. I'm so grateful that you did this, and I'm really familiar with Middletown and a lot of the cultural differences that people have in terms of not only their spiritual attitudes, but their sort of social expectations, especially about daughters in the family taking a role. And one of the things that we did in my family when we were in this circumstance, we asked the person who was clearly in need of care, what are your parameters? At what point do you want us to stop being the one to step in? And one of the things that was really interesting was the person said, I don't want any of you bathing me. That's a limit for me. That's a boundary. That's really important. My daughter-in-law thinks I'm this harbinger of death, but we do the Arthur Kaplan exercise at Thanksgiving, not every year, but every other year or so, to go around the table and ask everybody what they would want, and especially the younger people, like, well, you could be in a car accident tomorrow. What would you want to have happen? And it gets to be funny sometimes, but it still freaks out some people that we're so candid about it. And I think going into a community where you're an outsider, I really appreciate you explaining the amount of time that you took. This is my family and I forced them to do it, but you went into a community where you were really stepping in and needed to be tolerated and accepted. I think that part was really carefully done. I think you did a really nice job of that.
Thank you. Yeah, and I have to say that, I can't imagine doing this a different way. And the board members have all been very open. They're very passionate about this topic too. They all have loved ones, currently who are ill, and they are looking for a way for helping their own community out. So they've been fantastic. I mean, just being able to have the relationships has been wonderful.
Wonderful. Also, Andrew, we have one comment in the chat if you would like to read it from Dr. Steinberg.
Sure. Dr. Brett Steinberg says, thank you so much for sharing your work with us. Very much appreciated, especially in the context of current systemic changes that give little heed to matters that are consequential to all of us, but are not handled equitably for all.
Thank you.
Thank you so much, everyone. It's almost 3 minutes to the to 8. So Kyler.
Yeah, I better get going here. I gotta give my speech. So, thank you all for joining us this evening. And our next social justice event is going to take place on April 17th. It's going to be featuring Dr. Jessica Sardenia as our esteemed speaker. And I want to end by emphasizing that together, we are the facilitators for change and empowerment of individuals in our community. So regardless of the amount, your generous donation to the Social Justice Speaker Series helps ensure that education and awareness remain powerful tools for making a difference in our community. So with that, the donation link and mailing address are going to be available in the chat if you want to support us. And for those registering for continuing education, I invite you to complete that CE evaluation link to receive your certificate, which is also going to be added to the chat. And with that, once again, thank you for joining us this evening.
Thank you so much, everyone. And thank you so much. It was a great talk. Congratulations on your work, Dr. Parekh Campos.
Thank you very much. Thanks for having me.
You're welcome. Thanks, everyone. Bye-bye.
Thank you.
Bye-bye.
Christina, thank you so much, by the way. I was so happy seeing you tonight. Thank you for your presence.
This is just wonderful. And for all the work that I've done abroad, working with issues around death and knowing that death is coming, it has been so humbling for me to watch what is normal, what is typical, we had a terrible situation in which I was working in a refugee camp, and these people had made it over the border with terrible difficulties getting there, and they were in the camp and everything seemed safe. And then one of the kids drowned in a local lake. And it was completely unrelated to anything. We couldn't get a death certificate. They needed to wash the body. They needed to hold a service. And I just sat there thinking, I am helpless here. I got nothing. I don't. And when it finally happened afterwards, my translator said to me, he couldn't be in the tent with me. It was all women. He came later and he said, now we have to go back in this many number of days and you have to bring a present. You have to bring tea or you have to bring coffee I was like, okay, you tell me it just was so moving and important to have that help, to not go wrong. And it's all over the world. It's the same questions. How can you make this less painful for people? Whatever the circumstances. I should talk about something else with you when we have a chance. I have an idea for someone who might be a really wonderful speaker. But I have to ask his permission first to see if he would be available.
Wonderful.
And
That would you have my email.
It would be long distance.
Got it.
Thank you.
Looking
Thanks for
forward
doing
to
this
it.
one.
Thank you,
Okay.
Kristen.
Bye.
Bye-bye. Wow, such a talk. Thank you so much for your initiatives, Beth. That was a wonderful talk. Andrew, thank you for your teamwork. That's something that we need. We don't talk about these kind of things.
Yeah, I've actually just been thinking about this week of trying to find like good things to read on the grieving process and how people handle that. So this is like a really timely presentation for me because it's something I've been thinking about this week.
Yeah, interesting. Actually, now I'm thinking probably we can ask for some resources from Dr. Parekh Campos, right, Beth?
Sure. I'm happy to do that.
That would be wonderful.
Thank you.
Also, we need address and phone number also for the honorarium.
Okay. I will
That
follow
was
up with her and give her a thank you also.
Yes, yes, that was such a wonderful. It's the first time we are having this like really hard topic, difficult topics. And despite that, our marketing person is not in AM. I don't know what happened, but we had a good number of participants.
Good.
Yeah, yeah. So thanks again. Wow, that was wonderful. Excellent. Excellent. And for our April, I think we are all set.
Oh, good.
C approved and everything. So CNH right now is submitting information and those kind of things. So I will share with you. Also, there is another thing I will share next week with you all. Are you going to be in for for next week?
Yep.
I plan on it.
What'd you say, Beth?
I'm sorry. I plan on it.
Good, good. So looking forward to seeing you both next week. Thank you so much again, and thank you for these initiatives, Beth.
Alrighty.
Okay. Thank you,
Thank
Shiva.
you. Have a
Thank
good
you. Bye-bye,
weekend.
Andrew. Bye-bye, Beth.
Bye-bye.